Hi, everyone. It's great to have you here tonight at our Soft Health Deep Dive. I am Kaylee Lehman, and I lead the Military Special Operations Family Collaborative, which is a nonprofit public health initiative for the special operations community. This deep dive is a follow-on event from our August SOF Team Room. The Team Room is a legacy conversation we co-host with the Global SOF Foundation to start important community conversations and get practical health resources into our community. The SOF Team Room starts the conversation, but there's way too much to cover for one night. Now we host these deep dives to bring in the experts and dive deeper into the evidence-based care, the research that is out there, and to lead you to better care and good advice. This event is designed to engage experts familiar with the health and care of special operations and on high demand topics. We start the evening off discussing what we know about things like tonight's topic, traumatic brain injury and SOF. The doctors will discuss why it's a tough topic to learn about and to treat, how you can seek quality care, and why it's important to involve primary care provider and your family as you seek care, or even just looking for answers to questions you might have. If traumatic brain injury and the soft brain have been on your mind for a while, you may have already submitted questions. Our speakers have blended them throughout their presentation, but we also have time set aside for new questions that you might have. And during tonight's presentation, Dr. Mihalik will be fielding those questions along with the other experts here tonight. Please raise your hand or feel free to enter any questions you have in the chat tonight. We welcome you to share your experiences and any resources you may be aware of with those attending. You'll notice the session is being recorded. You're welcome to keep your camera off to avoid being recorded, but this is an important topic that many in our community want to hear more about and continue to learn about. So the deep dive recording will be made available following tonight's event through email, and it'll be posted on our blog later. Now, without any further delay, I'm honored to introduce our lead expert on traumatic brain injury and SOF, Dr. Jason Mahalik. Dr. Mahalik provided an excellent introduction to this topic during our SOF Team Room in August. He's the director of the Matthew Gefeller Center at the University of North Carolina, Chapel Hill, and the Chief Executive Officer of the Transforming Health and Resilience in Veterans, the Thrive program, which is a Avalon Network program, and has nearly 2 decades of experience working with elite military service members in brain health. So without further ado, I'm going to let him introduce everyone else that's here tonight and kick off the evening.
Wonderful. Thanks, Kaylee, for the warm introduction. And I just want to thank all of the attendees this evening for joining. I've been able to invite several of my colleagues that I respect deeply in this space. And so I'll take just a couple of minutes to introduce them to the audience. First up is Lieutenant Colonel retired Steve DeLellis. Steve is currently the Senior Technical Advisor and Director of the Fort Bragg Research Institute, a joint venture between the Geneva Foundation and Womack Army Medical Center. Steve served for more than 36 years on active duty. He spent 31 of those years in Army Special Operations Forces. He served in virtually every enlisted rank from private through sergeant major, every commission rank from second lieutenant through colonel, had 16 combat rotations and 6 conflicts, and probably has by far one of the most unique understandings of how to care for and manage traumatic brain injury among Special Operations Forces operators. Our fellow co-panelist is Colonel retired Jim Lynch. Jim is a primary care sports medicine physician who's co-founded the Stellate Institute. After serving 31 years in Army medicine, He's board certified in family medicine and sports medicine. He has extensive experience treating those that are suffering the effects of trauma. He has served in a number of combat deployments to Panama, First Gulf War, Iraq, Afghanistan, Syria, and several locations in Africa, and served as the command surgeon for USASOC's effort over in Africa for several years. Wes Cole is also joining us this evening. Wes is a research associate professor in the Matthew Gefeller Center at UNC Chapel Hill. He's also one of our research and clinical neuropsychologists in the Thrive program that Kaylee just described. He spent many years working at Womack Army Medical Center in Fort Bragg, starting there in 2009. He then transitioned to the Intrepid Spirit Center, which is a multidisciplinary TBI treatment facility for military service members, and spent most of his career there until joining us at UNC Chapel Hill. And then lastly, we have Jacob Powell. Jake is one of our doctoral students in the Matthew Gefeller Center and has really done a lot of work in this population as he's helped us with the broader project and the broader scope of our work, and now focusing on some of the SOF data that we have on the purpose of his dissertation work. So a lot of great academic and scholarly work coming from Jake Powell, and you should look out for that name coming up here in the years to come. So now that everyone is introduced, I do want to share some disclosures. The blanket statement that the views expressed here are those of us as presenters and co-panelists. They don't reflect the official policy or position of the DoD or the U.S. government. Additionally, in full transparency, I am the chief science officer and co-founder of a startup company, and some of the research data that we'll present to you here today that came from our research center in partnership with USASOC are data that are largely funded by and generated by grants provided by USASOC and US SOCOM. The other major disclosure that is not on this slide is that while we'll be talking about medical conditions, and in particular those around brain health, and some guidance and feedback will be shared, it is important not to misconstrue any advice that we provide as medical advice, and that if you have any questions about your treatment or the care that you or a friend are receiving, that you should contact your primary care physician for follow-up. So the format of today's presentation, we thought we would take advantage of all the wonderful and thoughtful questions that you have shared in advance. Many of you, when you registered, had an opportunity to submit some questions that were shared with us as the presenters and for this evening's session. And so we'll approach this as a little bit of a Q&A, and we'll sprinkle in some research and some updated information as it's relevant to some of the topics to give you a bit of depth and breadth in the work that we've been doing on the soft brain. And so that's it's pretty much going to be the approach. Some of the questions that were shared with us were clustered around kind of general questions related to TBI and TBI health and treatment. There were some questions regarding how to seek interventions or some emerging research in this space, as well as how to involve the family and how to find care or provide care. So there are going to be questions that emerge over the course of the next couple of hours that fall under these, 4 general buckets, if you will. And we're excited to get going and to walk you through some of those discussion points. One of the first questions involved symptoms and what are things that you can look for in individuals that have suffered mild traumatic brain injury. And really, to begin with, it's important to note that much of what we know about traumatic brain injuries in general has stemmed largely from civilian data, and then porting that understanding into seeing if the same lessons could be learned in a military or a service member population. Much of what we know about traumatic brain injury, unfortunately, comes from studying individuals that have already sustained one. We know that there are cognitive declines. We know that individuals with a concussion history or an mTBI history are more likely to sustain a subsequent injury, and possibly those injuries take longer to recover. We know that balance and vestibular issues come into play. Our understanding of the injury has evolved medically, and so we have a better understanding of how we evaluate the injury and how we manage the injury. So the physical exam considerations are much improved. It's not enough to know that someone's not feeling well, but we need to know how many symptoms, the clusters of those symptoms, the severity of the symptoms, so that we can guide appropriate and focused acute care for anyone that has sustained a mild traumatic brain injury. There's been a lot of work in the knowledge and attitudes and behaviors around TBI reporting and care seeking. And fortunately, even when we look at our high school athletes, individuals who have a previous history of concussion are actually less likely to report a subsequent injury. And so we see those care-seeking patterns also emerge and extend into a military population. And that's actually the exact opposite of the direction that we would like to see that go. And in the black box, we've got treatment, because as many of you know, if you're joining us this evening, there are a lot of unknowns and a lot of uncertainties around how we treat TBI, both acutely and in the long term. And our hope is that we can get after some of that information here this evening together with all of you. I skipped over mechanism of injury because in the sports world, we're primarily concerned about blunt trauma, those types of body checks and tackles and the types of collisions you might see while you're engaging in watching sport. And in the military space, there's also a good propensity for blunt injuries as well in training and operational engagements. But there's also the blast mechanism that is hard to disentangle from blunt in kind of the acute management of TBI. So that's something that we're exploring a little bit more, and we'll touch on here as we move through. Over the years, we've realized that it permeates well beyond this cluster of conditions that you see here. We know that the vision system is affected. We know psychology is affected. We know that physiology is affected, and we'll touch on some of these things throughout tonight's session. There's recent evidence to suggest that those who sustain an incident concussion or an incident mTBI are more likely to sustain a subsequent musculoskeletal injury, sometimes 3 times more likely in the 3 months following injury than a fellow service member who has not sustained an mTBI. So while there's a challenge for some individuals to report and to manage or to sit out some time to appropriately manage that acute mTBI, there's the secondary effect of if that TBI is not treated properly or not reported properly, there's going to be a musculoskeletal injury, almost a 3-fold risk of suffering one in the months to come, that likely are going to sideline that individual for a considerably longer time. And so those are discussion points that are starting to be raised with commands. And then I touched on the blast injury mechanism as well. So the first question that came in, and we've reordered the questions that were shared with us in advance for the flow purpose of this. But one of the first questions that was raised was, what are the subtle symptoms to look out for, especially as a spouse? And that's a really good question. On the clinical side of things, we've often asked our athletes, how they feel. Most of our civilian work at UNC involves our varsity athletes. There usually isn't a spouse or a significant other that comes with them to their appointments. But when we work with our veterans, when we work with our retired athletes, when we work with professional athletes that come to see us, oftentimes they will bring a spouse. In fact, we will insist on it. And we'll ask the same symptom inventory to both individuals, sometimes in separate rooms. And it's very interesting to see the disconnect between what is being reported. Someone may feel like they're fine, and their spouse may report, he's snappy with the kids, or he flies off the handle a lot quicker than normal. And so those are the things to kind of look for. When we look at the symptoms that we usually inventory in the civilian sports space, you see them listed here. I'm not going to go through them all. The ones that have the double asterisks are also the ones that are in the military acute concussion evaluation form, or the MACE. So there's some synergy between what we do in the civilian world and what we do in the military world. But some of these are pretty straightforward, right? Someone has a headache, my head hurts, you could probably track that pretty well. Someone who has blurred vision, who doesn't report it, that's a bit more challenging. Someone has difficulty concentrating, that'll be something very subtle that a spouse may or may not pick up on. So it is a big challenge, but hopefully by sharing these symptoms here with you, it gives you some insight as to what to look for. The bottom line is that no 2 concussions or no 2 mTBI are identical. Injuries will always appear differently from one service member to another, and even from one service member's injury to their next injury. And so I don't say that to make this an even scarier landscape for spouses, but just to raise awareness that if your husband or your spouse has sustained an mTBI and they present it in one way, And the next time they're not presenting that way, don't dismiss the fact that they might still have an mTBI. It just might be presenting in a different manner. We realize that this is a complex landscape. And so Steve in his work with USASOC has kind of spearheaded very, early, about 15, 20 years ago, a desire to better appreciate what the service member is experiencing on a regular basis, particularly the SOF operator. And so with that said, I'll turn it over to Steve to kind of talk a little bit about why this question is important, in particular, what I'm sure this was a question that was asked of him many years ago to prompt some of the work that was done earlier in our partnership together. So that said, I'll turn it over to Steve.
Thanks, Jason, and thanks for allowing me to be here and spending some time with you all this evening. I can truly talk about TBI all day, every day. It is such a huge problem. There's plenty we know. There's even more that we don't know, and a monumental effort has gone into looking at the problem and attempting to solve the problem. And unfortunately, there's a lot of hearsay and anecdotal evidence out there when it comes to TBI. And really, I think it's our goal and the goal of the team we've put together, and the brilliant minds I'm joined by here tonight to ensuring that you have the good science to fight this problem. So as Jason mentioned, we started this effort somewhere back in 2002, and it really had nothing to do with traumatic brain injury. We were interested in whether computer-based neurocognitive assessment tools could predict success in a special operations selection process. And the answer is ultimately yes. But if you'll notice the dates on the timeline there, you'll also recognize that that was the kickoff of a very long and protracted war that was just rife with traumatic brain injuries. And the way we went about looking to see if we could predict success was by baselining operators, and then by baselining those folks that were going through the selection process and following them through the training program to follow. Well, over time, as you can well imagine, some of those warriors had traumatic brain injuries, or were subjected to forces that could potentially cause a traumatic brain injury. So, having had their baseline assessment on file, we decided to go and retest them, post-injury test them, and compare their post-injury test to their baseline test. And what we noticed, and we were using the ANAM at the time, the Army's version, the DoD's version of the neurocognitive assessment tool at the time was the ANAM. And it was problematic to use in that we had to constantly run back and forth to Walter Reed to get answers as to whether there was any change, significant change between their post-injury assessment and their baseline. But there was, and we were able to tease out some of the problems, but we also realized that there was a problem with the test itself. And somewhere around 2004, 2005, we started looking at some of the commercial tools that were available out there that professional sports teams, collegiate sports teams, and others were using to assess their players on the field. And we ran a head-to-head comparison between the ANAM and several other commercial products. And ultimately, we settled on a test called the Immediate Post-Concussion and Cognitive Testing Tool, or IMPACT, that was developed by the folks at the University of Pittsburgh with the Steelers. And it was our work that convinced USASOC to adopt the IMPACT over the ANAM for special operations forces. And we eventually got USASOC to agree to baseline all of the special operators we were putting into combat, so we would have their own baseline on file to which we could compare them if they suffered a traumatic brain injury. And that proved to be very helpful. Unfortunately, we also learned that a single point failure test is not the best way to do business. So we started reaching out to the true professionals in the field. We reached out, as I mentioned earlier, to the University of Pittsburgh and the Steelers head injury team. We reached out to the University of Rochester, was doing a lot of work with blood-based biomarkers at the time. And it was at a University of Pittsburgh meeting, I was fortunate enough to meet the Gefeller Traumatic Brain Injury Center team, and learned that they had quite the capability, much closer to home than the UPitt team, which would save time, money, and travel when it came time to baseline and post-injury test our folks. And that's really where our relationship with Gefeller, between Gefeller and USASOC started. And we sat down and we invited a bunch of people to come join us at the table and figure out what might a holistic approach look like in assessing folks at baseline and then again at post-injury. And we were very fortunate enough to have a commander at the time that was willing to bankroll the effort, so we didn't have to rely on external funding. We were able to put this test bed together very early on with very little hassle at all. And what we ended up doing initially was imaging our warriors with 3 different imaging modalities: MRI, DTI, and SWI, drawing about 8 or 9 different biomarkers, serum-based biomarkers at the time: oculomotor, vestibulomotor assessment, hand-eye coordination, and balance, et cetera, and put together kind of this holistic picture of what the operator might look like when they're healthy, and then repeat that after they were exposed or injured. And somewhere around 2009, we put that effort into production, and that effort continues today. And one of the things I'll tell you is I really hate the idea of lumping people together as with a diagnosis of TBI. In my opinion, TBI is a mechanism of injury, right? When a patient falls on an outstretched hand and breaks a bone, we don't diagnose them with a fall on outstretched hand. We diagnose them with a broken forearm bone, whatever that may be, a radial fracture of the ulna or whatever. And unfortunately, I think early on we lumped everyone together with a diagnosis of TBI, and that's okay as long as we tease out what's wrong with the patient and actively work to treat those problems and the sequelae that those patients are actually suffering from. And Jason mentioned treatment earlier, and treating a patient with TBI is challenging, but we have ways to treat patients with nausea, and we have ways to treat patients with vergence and accommodation problems. We have ways of treating patients with insomnia. So let's tease out what's actually wrong with the patient. Since there's such a heterogeneity to this problem, let's work on what's wrong with the individual patient so that we might return them to play or might return them to duty. Next slide, please. So, there's a lot we know about TBI, but there's even more we don't really understand, and we don't really understand who is most susceptible, or although there is some evidence out there that there may be some genetic predisposition to worse outcomes in TBI. We know that some medications might potentially affect cognition in a way that a traumatic brain injury might cause them to not respond as favorably. But we also know there are some medications that actually help cognition and some of the sequelae of TBI. And as Jason mentioned earlier, we also know that there's a temporal relationship between traumatic brain injury and musculoskeletal injury. So putting soldiers back on the battlefield or putting athletes back on the playing field when they're not completely recovered from a traumatic brain injury not only sets them up for another traumatic brain injury, but it also sets them up for potentially game-ending or career-ending musculoskeletal injuries. We also now know that there's some correlation between peripheral injury and direct injury, and a lot of that evidence has come out of Iraq and Afghanistan, but we're not quite sure why. And we also know that there are some folks that respond very favorably to exercise following a traumatic brain injury, but those are specific folks within specific cohorts. You can switch to the next slide there, please, Jason. So what we would really like to know, and what I think commanders would like to know, or coaches of sports teams would like to know, is when can I put my soldier back in the field? When can I put my player back on the playing field, right? Do supplements help? Is there something I can give my players? Is there something I can give my soldiers? How much sleep is too much sleep? We know sleep is restorative, but we also know that sleep is a problem following TBI. And again, I mentioned the U-PIT work that suggested that some folks respond more favorably to exercise after a concussion, but then again, there are some folks that don't. So we really need to tease out those populations that may respond favorably to the treatment protocols we're using for those individual sequelae. Next slide, please. Yeah, so we plan to continue our effort that we've been running now since 2009, and that protocol has morphed over the years. The protocol we're using today is vaguely similar to the program we started in 2009 in the sense that we're still using imaging techniques. We're still drawing biomarkers, but we've kind of expanded the aperture a little bit to include others in the community, a cohort from the Special Forces community, a cohort of aviators, and now for the first time, pulling in some retirees so we can get a snapshot at the beginning of career and at the end of career. And we're working diligently with some sleep professionals to better understand whether we can actually improve sleep by helping clear the glymphatics and the sludging that occurs following that neurometabolic cascade that occurs after traumatic brain injury. So lots of work still to be done. The effort continues, although with a little bit of tweak as we go. And Jason, I think that's it for me here.
Excellent. Thanks, Steve. The next question that came up that we want to address is plainly stated here: are most TBI patients examined with functional magnetic resonance imaging, or fMRI? And the bottom line there is no. In fact, this is extremely rare for someone in a clinical environment presenting at a clinic with concussion to be imaged with this type of technique. In fact, it is very rare for someone to present in a primary care setting with a concussion, civilian or military, to obtain an MRI at all. So an MRI and a CT scan are more likely to be used in urgent scenarios, so emergency rooms. They are designed in their current kind of structural picture taking, if you will, to identify things that could potentially kill an individual. So things like skull fractures and brain bleeds are things that MRI and CT currently look for. So once you rule those out, you've essentially ruled out, severe TBI, and then you're left with good sound clinical judgment and patient interviews. So fMRI is primarily used as a research imaging modality. So a lot of researchers who study TBI patients will employ functional MRI, but it is not part of the standard of care. And to have a one-off patient come in under which you conduct an fMRI, it's very hard to look at that person's data and make any sound, reasonable determinations. In most studies, we have a larger group of individuals who undergo fMRI, and then we could look at them as a group or as a cluster. And so that's what's typically done on the research side. By definition, in the civilian sports world and now gravitating towards the military environment, mild traumatic brain injury is not observable on MRI or CT scans because it's very much a functional injury and not a structural injury in most cases. And so the simple answer to the question is no. In fact, it's a very rare imaging technique to be done in a clinical environment. Having said that, there are advances in neuroimaging and ways to look at the brain that we are actively working on here at UNC to explore and to understand the soft brain. And so Steve alluded to the program and the partnership that we started over a decade ago. It is now kind of branded under this term Attack Forces Initiative, which stands for Assessing and Tracking Tactical Forces. Taking Steve's earlier timeline and building on it, our first visit with Steve was January 7th, 2011. Our first cohort coming through was 1 year following that. We've been studying essentially every training pipeline cohort since then in the Matthew Gefeller Center, and we've been doing a myriad of tests with them. Steve touched on most of them, but primarily we've been looking at neuroimaging. We've been drawing blood, analyzing some biomarkers. We do some human performance work around vision and sensory performance and musculoskeletal screening because we want to provide near-term reports to some of the individuals that we're working with so they can improve themselves in that regard. We conduct standard traumatic brain injury clinical measures, and we started to explore some transcranial Doppler. Having said that, I'll come back to the transcranial Doppler piece, but I'm going to turn it over to Jake, who's going to talk a little bit about some of the neuroimaging work that we've done, primarily around paravascular spaces, as well as some innovative, graph theory approaches. Jake.
Thank you for having me. So I primarily like to emphasize that my goal as an imaging researcher is not to make a diagnosis of TBI, but to study the ongoing changes to the brain following that TBI after the clinical recovery. Thankfully, we know that most mTBI do recover clinically. And what I mean by that is the symptoms resolve, the soldier returns to duty, the athlete returns to play. But then there's a period of time where physiology may change, and those changes to physiology may link that TBI to long-term neurological consequences. So Jason, if you could please go to the next slide. One of the systems we're looking at that may connect mTBI to those long-term adverse outcomes is the glymphatic system. The glymphatic system is a recently described waste clearance system that uses a series of paravascular channels to eliminate brain waste, so proteins, metabolites. That functional injury of mTBI really produces a fair amount of cell death and cell debris, and all of that has to get cleared out of the brain to reduce toxicity, decrease neurodegenerative disease processes. And we know that this is preferentially affected by sleep. So if you're not sleeping, the glymphatic system is not pumping out those wastes. Anecdotally, neuroradiologists have observed enlarged or MRI visible paravascular spaces, primarily on T2 weighted imaging, clinical imaging, and described as T2 white matter hyperintensities. Until recently, not until recently have these been described as enlarged paravascular space lesions. If you could go to the next slide, please. So here at UNC, we've developed a technique for actually imaging and segmenting out those paravascular spaces in the white matter of the brain. And you're looking at one example, but our research has shown that in soldiers that have sustained mTBI, we do see enlarged MRI visible paravascular spaces, which may indicate impaired waste clearance. And while this is an identifiable physiological outcome, we are confident that we may be able to treat something like this with a sleep intervention. Next slide, please. Another way we're looking at the brain is through fMRI. Again, not as a diagnostic tool, but as a way to describe what the brain following mTBI looks like. So one of the ways we do that is we take the fMRI, and a quick primer for those not familiar, what an fMRI, a resting state fMRI in this case, does is it looks at the brain across about a 10-minute scan. And for lack of a better term, voxels or regions in that brain light up. And when two regions light up together, there's a functional connection. There must be a link between those two regions of the brain. And over time, we can compose this series of turning on and turning off regions into a map of the brain or a complex network. And we can use the mathematical field of graph theory, which is just a fancy way of studying complex networks, to describe certain traits of that network. One of the things we can get at is how efficient that network is, how long it would take to get from one part of the network to anywhere else. And what we find in mTBI is that, at least in that subacute phase, those with a high mTBI history can maintain their brain network efficiency, but there's an underlying change to brain network resilience. What you see here is a network moving to a more vulnerable, more highly clustered state as mTBI incidence increases. So in this first network, we see the connections are sort of haphazard and random, but there's a fair amount of redundancy to this network. And in the second image, you see the hubs sort of cluster, where hubs with high degree tend to connect to hubs with lower degree. Where these networks might be equally efficient, the second network is clearly more resilient to a future injury or a future insult. And this is one of the mechanisms we think may cause those with greater mTBI history to be at greater risk down the road for these long-term neurodegenerative or neurobehavioral outcomes. Thank you.
Thanks, Jake. Another question kind of in line and one that we might be able to build on is what physiological measures exist outside of post-mortem assessments? And one of the conditions that was raised was CTE, or chronic traumatic encephalopathy. And the bottom line up front here is that when we use the term physiological, it's a very broad term, and it can encompass so many things within the body, and it could range from blood biomarkers to neuroimaging, as Jake just described, autonomic system measures, and so on and so forth. In relation to CTE, there are some advances in imaging techniques that are being explored in the research realm. PET-CT and PET-MR imaging are showing some promise using tracers that are injected prior to imaging. And so these tracers, and a popular one is the 18F fluortaucipir. Fluortaucipir is a tracer that's actually been well received in the Alzheimer's disease world. These are tracers that are injected that bind to certain proteins that we that are characteristic of a condition that we're looking for. So in Alzheimer's, it's tau depositions in certain areas of the brain. And once they're bound, you can then run them through an MR, and you get these, these images like you see here on the bottom of the screen of the brain that get lit up because those tracers are very visible on those imaging modalities. And so there are other tracers that are being explored for the purpose of CTE. And while it also is a condition that is known to have tau and amyloid beta depositions in the sulci of the brain, the characteristic location of those or the presentation of those don't necessarily align perfectly with Alzheimer's. So the tracers used in Alzheimer's don't tend to work as well to identify CTE and other types of conditions like it. So we're exploring investigative tracers. They are a challenge to incorporate in the research space. Right now, there are a small number of FDA-approved tracers for the purpose. We license the recipe essentially from the companies that own the IP around those tracers. We have a radiochemist who has their kitchen essentially in our imaging center, who creates and fabricates the tracer. We inject it. They have very short half-lives. And so it's a really big logistical challenge to conduct this type of work. But there are ways for that particular condition that we're advancing some of our science. Another physiological way to look at the brain that isn't in an MRI scanner is using transcranial Doppler. And there's a couple of methods around how we do it. But when you look at the skull of a human, there are 3 windows where ultrasounds or ultrasonography can actually penetrate the skull reasonably well. One is in the suboccipital area, which is an area to the the backside of the head, if you will, through the orbit, obviously through the eye, and then the temporal region, which is right here on the side of your face. Most of you know that. Our work focuses on capturing some of these cerebral blood flow markers through the temporal region. When you look in the temporal region, there's 3 primary arteries that you can capture blood flow from. One is the anterior cerebral artery, one is the middle cerebral artery, and the other is the posterior cerebral artery. We applied 2 different methods to it, and our focus is on middle and posterior cerebral artery. With respect to the posterior cerebral artery, this is the area of the brain that when we capture allows us to look at something called neurovascular coupling. And I credit these slides and the data I'm going to share with you with Dr. Tricia Roby, a former PhD student in our program who's now working on a postdoc at Penn. And what we do for the visual stimulus around neurovascular coupling is we give our special operations forces soldiers 2 tasks. One of them is a basic reading task. We usually choose an article of interest to them. It's usually some ESPN article or some fantasy football article, something that'll keep them engaged for the task, which is 40 seconds of reading. And then we take a more challenging visual search task. And for those of you who are familiar with the Where's Waldo books of long ago, we take a couple screenshots from that book. Our folks have digitally removed Waldo from the picture so we can ensure that they are engaged in 40 seconds of search. If you want to frustrate a SOF operator, put him in front of where's Waldo, ask him to find Waldo and purposely remove Waldo from the picture. So that usually gets a little bit of frustration from the group. And then there's the other individuals that claim to find him 7 times. And so we know they're clearly lying. But when we look at the data, and we look at the velocity of the blood flowing through the posterior cerebral artery during that task, and we look at those with no history of concussion, or at least TBI naive, and then we look at those with a concussion history, we see that there is separation and increased difficulty with the task of the visual search. So the visual search, which is a more demanding task, commands more effort and more resources within the brain as we're able to measure looking at cerebral blood flow. When we take the concussion history group and we probe it a little bit further and we look at those that have 1 or 2 previous injuries compared to 3 or more, we see that it's those that have 3 or more previous concussions that are really driving this difference in the amount of resources that are used in this space. I mentioned that when we talk about physiological markers, this also includes blood biomarkers, and I see some discussions going on in the chat, and thanks to my co-panelists for answering questions as we go through here. But I want to turn it over to Jake, who's led, in fact, has published on some of our work with neuroinflammatory biomarkers in this population to talk a little bit more about some of our findings there.
Thank you. So, as Jason said, our work has also encompassed blood biomarkers, and I approach biomarkers the same way I approach neuroimaging, in that it would be very challenging to use them specifically to diagnose mTBI. One of the key reasons is mTBI, by definition, is a diagnosis made on symptoms. We also know that the symptoms of mTBI may resolve before the brain is physiologically recovered. So if symptoms are considered the gold standard, then in theory, the physiology would be an improved measure, but there is no way to go back and create a better diagnosis than that symptom diagnosis. So what are biomarkers really good for? Well, if they can describe the ongoing physiological changes to the brain, they can be linked to a tissue injury, and that tissue injury can be used to describe those brain changes and predict long-term outcomes. So our current work encompassed 104 SOF combat soldiers. The question we asked is, what is the effect of mTBI history and the effect of mTBI recency on a variety of blood biomarkers taken from a spectrum of neurological sources or tissue types? So that was neurofilament light, which is an axonal protein indicative of white matter injury. Neuron-specific enolase, which is primarily expressed by the neuronal cell body, or the gray matter. S calcium binding protein, or S100B, indicative of neuroinflammation and expressed by astrocytes, and then IL-6, a sort of non-specific cytokine indicative of inflammation. So our key findings for this study were neuron-specific enolase was elevated in soldiers with mTBI history, and when that was probed further, the soldiers with 3 or more mTBI compared to 0 were really driving that difference. So similar to our findings with neurovascular coupling, it looks like there might be a point at 3+ where neuronal decay or neurodegeneration sort of sets in. And what's interesting about this finding is NSE has a relatively short half-life. So if we can measure it in the blood, it means that there's some sort of ongoing process or ongoing degenerative process going on that's continuing to replenish the NSE supply in the blood. We also found that S100B is greater with more recent injury, but subsides with longer recency, indicating that there is probably a neuroinflammatory cascade ongoing with that neurometabolic cascade. It may exceed symptom resolution, but tends to resolve. One fascinating finding of the study were there were no differences in recency or mTBI history based on NFL concentrations or neurofilament light concentrations. However, these neurofilament concentrations were similar to a civilian population that had sustained a much more severe TBI, even a life-threatening TBI. So our special operations forces tend to sort of walk around and be healthy with extremely high concentrations of neurofilament, indicating potential white matter degeneration that's not linked to mTBI history or recency, but maybe some aspect of training. So how do we move forward from this? Well, it needs to be linked to this neurophysiological timeline. How can we apply physiological variables like blood biomarkers, neuroimaging, or any of these advanced measures in a meaningful way? We need to understand the initial injury. That's when symptoms are onset and there's mechanical cell damage within minutes. That neurons get stretched out, that myelin is degraded. There's a metabolic efflux of ions, which cause dysfunction in the cell. The cells need more energy than they have available. If they can't get that energy, and there is a concurrent decrease in cerebral blood flow, dysfunction sets in, inflammation sets in. If that cell can't get enough energy, it will lyse itself or go through an apoptosis process. If that axon's even completely severed, the cell may not actually die. The connection will simply be severed, and that will be broken. But we do know that this process tends to recover. So in most cases, there is physiological recovery, but I've left a question mark here. There's a sort of different trajectory, and that's what our science aims to get at. Is there permanent damage to these neurons? Is it specific to a tissue type? Can we measure it physiologically before symptoms onset and then use that window of opportunity to intervene?
Thanks, Jake. Now I'll turn it over to Jim. Jim's going to kind of talk about the evolution of the Attack Forces Initiative over the years. It started initially as a program for those who completed the training pipeline, but we learned through some of the data that Jake shared and presented and some of our findings in otherwise healthy individuals that there were some physiological differences there, and it caused us to kind of think about how we could expand programming to support those SOF operators throughout their career. So the question that kind of prompted us to input this part of the discussion was, if not diagnosed when the traumatic event occurred, how can you build back to understand the evolving impact over time around mental health and headaches and any other symptoms? And so recognizing this is a very important question, not just for the individual who submitted it, for those in attendance today, but for the command of those overseeing active duty service members, we also realized this was an important consideration as well. So I'll turn it over to Jim to talk about the evolution of our evolution protocol.
Yeah, hi, I'm Jim Lynch. I recently retired from the Army after 31 years, and I just want to pause for a second. We've been going about an hour, and this is some very dense information. This is some super thick topic, and I think it's helpful in the spirit of the SOF team room that what our goal ought to be is really where the rubber meets the road, and for us to focus in on some actionable type things. The group of people that are presenting here have lived, breathed, and been immersed in this topic for so long, and it's awesome to have someone of Steve DeLellis' background to have brought us together, steered us in the right direction, and continue to steer us in the right direction. But there may be some of you listening to this thinking, wow, this is a lot of really good and interesting information, but what do I do with it? And I think that was the lens that I looked at things through as a command surgeon in a special mission unit at Fort Bragg, with those specific questions coming out of team rooms that were, okay, we know that there is some potential damage to what we do in our jobs. We know that, and we're not stupid. We're also not willing to just quit because we think that our job is risky to our brain or otherwise, but what do we do about it? And I think what's helpful in a partnership such as this, where there are researchers at a center of excellence at UNC Chapel Hill, and then there are folks who are deploying constantly for the past 20 years, that's a perfect solution to really dig in and make some practical gains in this matter. So I'm just going to talk a couple of slides here just to shift gears a little bit out of the lymphatics and inside the brain to just out in the units. And what we were given is an opportunity then to take the questions that were being asked and then figure out, hey, how do we apply these? How do we answer questions like, what exactly about our job is dangerous? Is it permanently dangerous? Is it temporarily dangerous? And how do we know? And what do we do about it? And what things can we do for treatment? But what other things can we do for prevention? And these are all really important practical questions for people who are SOF operators and really the focus of what we should be doing here in the SOF team room. So you'll see the slide in front of you really, which was, this is in retrospect, we designed several individual programs over the course of several years to track an operator throughout their lifespan in terms of monitoring and surveilling the things that's already been discussed by both Steve and Jason earlier, and Jake as well, in terms of measuring things like biomarkers and neuroimaging and balance and cognitive performance. The idea then is, okay, how do we expand this so that we just have a better understanding of our population, of our units, and how can we do that at periodic times throughout the lifespan of an operator? At the unit where we serve, we were fortunate enough to have operators there for the majority of their career, and right at Fort Bragg, stay in one spot. So it was really kind of a nice way to test and evaluate things. But this is not necessarily unique and could be applied across SOF, which is how do we get a more holistic look at people as they come into a program? How do we measure that periodically? And then how do we intervene as necessary? So what you'll see here is, the AWARE program that has been discussed previously essentially was baseline measuring of operators as they come into the training pipeline for a special mission unit, and then periodically re-looking at them. And this is the piece that had been essentially missing until we were really learning on the fly. And as Steve described, this was multiple iterations of learning as we go. But this is what became readily apparent was the job of those of us in the medical community who are trying to support the warfighters. We really ought to be principally focused on the sustained optimal performance of our operators, sustained optimal health and performance, and that's really the critical thing. And the sustain there is really the key word, because it's easy to look at short term. We look at a baseline, we look at a blast injury, we measure things before and after, we guide treatment on that way. But it's kind of missing the holistic look. So what we tried to do is, over a course of several years, design a layered approach within a special operations unit that would then start off with screening early on, both to assist in selection into the unit, and then an early training or initial training in the unit, such as in an operator training pipeline. What that allows us to do is then have a really good baseline understanding of where our warfighters live and operate at. And then over the course of a warfighter's or operator's lifespan, there's multiple opportunities then to relook, and it ought not necessarily be triggered by an event. So aside from the obvious, we should look at people closer after they get blown up. Okay, so that's an obvious thing, and that has been done for quite some time. But what if we built into that some periodic and routine assessments that were maybe more practical than a post-deployment health assessment, a post-deployment health reassessment, which the big Army and SOF had adopted periodically, but essentially would become pencil whipped or just finger drilled if there were not some practical tasks that came about that. So what we decided is that we could take this on ourselves and build a system where this layered approach allowed for a deeper dive at periodic iterations. And some of those were kind of obvious places. As an operator advances in career and takes on greater responsibility, some of the shoot, move, communicate then becomes more leadership, managerial type exercises. And those tasks sometimes become challenged due to injuries sustained early on. So there are some obvious gates for us to go ahead and look. So down in the slide that you're looking at there, there's a lot of words on there, and I'm not going to obviously go through all this, but I will draw your attention to this one that's called evolution protocol, or what we later abbreviated as EvoPro. But the idea here was really born out of experiences that many people have had at NICO, at the National Center for Intrepid, in Bethesda, as well as the Intrepid Spirit Centers around the DoD at different duty stations. But the concept and the experience for many people was that level of fine-tooth comb of going through our health history with a very close look under the hood, looking at all systems, adding imaging and labs and whatever, was a very helpful process. What could we do to build that in or bake that into just how our unit does business as usual? So essentially, we created like a mini NICO 5-day program, which we called the Evolution Protocol, or EvoPro for short, that was staffed and run by the unit's medical personnel in conjunction with the folks at the Intrepid Spirit Center, in this case at Fort Bragg, although there are many about the DoD, so it would be an easy thing to replicate and franchise essentially. But the concept then is, at routine intervals, we can look at the same measures that were taken at baseline, and without a specific prompting, we could go back and reassess those things. So this allows for an individual operator to get a really good look under the hood at a periodic time in their career. What it allows for on the other side is the former speakers that have been presenting here tonight to gather a lot more information and to really make a very solid assessment. And a lot of the questions that people will ask then is, well, I may not have been blown up. I may not have been thrown from a vehicle, from an IED blast, but I've suffered tons of low level concussive blasts from firing AT4s, whether it's at the range or deployed or whatever. I have had all these exposures in my period of time, or I have had blunt concussions from combatives, or fallen off a fast rope, or whatever. All these things may happen that may not warrant a specific look in the medical system. But if these things happen periodically as part of an individual operator's job, right, daily duties, then we'll have an opportunity to reassess those at a period of time. So the slide that you're looking at there is essentially just an example of what 5 days look like, of a really close multidisciplinary look under the hood at an individual cohort of operators from our unit that we would run several times a year, again, staffed from the clinicians within the unit and paired up with the Intrepid Spirit Center, in this case, run actually physically at Fort Bragg. And what that allowed us to do is give an exit brief or an overview of the overall health in multiple facets, actually very similar to the first slides that Jason showed about all the different domains that feed into TBI. And the important thing to mention here is, while a lot of this concept was born out of TBI and brain health specifically, whether that's TBI or PTSD, what we discovered there was a whole ton of overlooked health issues. And it could be everything from hypertension, hyperlipidemia. Eyesight was a major discovery for us, of things that were just kind of glossed over and missed because we didn't have a really good opportunity to look at operators in a really holistic way. So again, EvoPro was an example. I'm happy to talk more discussion, if there's more specific questions later, but I'll pass it off now.
Great, thanks, Jim. And as Jim mentioned, this EvoPro week is done periodically throughout one of the SOF operator's career while it's Special Missions Unit. And because we've been doing this partnership for well over 12 years, there's a high number of individuals going into this under the hood check for which we have baseline data once they join the organization. So we're growing a very rich data set of retest time points on all of those physiological measures that we described as being part of our protocol. Jake is taking some of that work to look at changes in neuroimaging and blood biomarkers, and overlaying in the time period between baseline and when we reevaluate them, all the measures related to training blast exposure that we've captured from blast sensors worn by the soldiers, directly by sensors being placed in their environment by the safety officers at the post. So we're building a really rich database, and we're just now starting to dive into what some of those test retest data points look like. We also are funded under SOCOM's grant to also look at a pilot study, I would say pilot study, a preliminary study of SOF operators, not pilots as in aviators, but individuals that spent a career at the SMU, who have retired, who are now in veteran status, because we really wanted to paint this picture of what it meant to be SOF for life. And so we're really building a robust data set that I think is unique in SOF. And unmatched in most places. In large part, I give full credit to the vision Steve had 14, 15 years ago to start this whole process out. We're right on time. We're about 2 slides away from a panel discussion where we'll entertain some of the questions that have popped up in the chat that Wes or Jake have been unable to answer. But the first question here that we'll go through is the potential impacts of TBI to the endocrine system, specifically testosterone. And this is a question that came up by one of the registrants, and I'm quite confident, given the number of times this question comes up in conversation, that many of you share it. The bottom line is that there is no direct causal link to testosterone, and whatever direct causal link might exist is very unclear in the scientific literature. Testosterone as a treatment also is not strongly supported with respect to treating TBI. Having said that, there are things in the endocrine system that do kind of get a bit of a red flag, if you will. We know approximately 20% of all mild traumatic brain injury cases result in some level of acute hypopituitarism. The question is, at what point does that recover? Does it ever fully recover? And what the long-term implications of a mild traumatic brain injury insult, or 2 or 3 or 10 or more in a career might lead to in this particular area. Sean Kane, who was Jim's predecessor as command surgeon for the Special Missions Unit, had an interest in looking at some of this. And so we explored some of the data. And what we found in combining our imaging and our biomarker work was that individuals that had a greater, and when I say individuals, I mean specifically SOF soldiers, with a greater mild traumatic brain injury history had lower or smaller anterior pituitary gland volumes. And that correlated very strongly with lower IGF-1 concentrations in serum. And IGF-1 is a serum kind of systemic biomarker, if you will, a surrogate for growth hormone. So there is something that's occurring in individuals with a pronounced mTBI history to the endocrine system, such that we were able to observe this with respect to the anterior pituitary gland, which produces growth hormone and ergo IGF-1 in the systemic circulation. What we also found, though, is that only one of the 74 soldiers that we studied actually exceeded an established reference range. And so for us, that suggests that there is a that elevated values of these outcomes, for example, might actually be the norm for SOF. And again, this all goes back to our discussion in the conference room, 13 years ago with Steve, where we're applying a lot of science, we're applying a lot of measures, if you will, to this population, and then benchmarking them across population norms. Well, anyone who's been involved with this population or has been a part of it knows you're not normal. And I don't say that in a disparaging way. You are intentionally selected because you are different, and you could function at a very different level than what I could as a civilian, driving my kids to school every day and going to work and doing what I do. So there is a need to study SOF specific populations. I think one of the problems with many of the questions being asked is, despite there being some answers, there aren't a lot of answers specific to SOF. And we know that individuals engaged in SOF are different. Another question that was asked, and then we'll roll into our panel discussion, is what is the prevalence of seizures that are brought on by TBI within the SOF community. And I'll just kind of summarize the science around it. There are weak retrospective studies, particularly chart reviews, that suggest that TBI and or PTSD are associated with an increased risk of experiencing a seizure. Having said that, there are no strong longitudinal prospective epidemiological studies that really track this, and specifically don't track it in a soft population. And in the blunt space, particularly around civilian mild traumatic brain injury, it is extremely rare, at least clinically in my background as an athletic trainer. And I think Jake could concur with this, and Jim in his work with Olympic athletes can attest to this, likely that it's very rare in civilian concussion type injuries. I'll invite Jim to maybe chime a little bit more on this, given his experience medically, and Steve as well, given his time as a PA in RSOF, to kind of talk about their own personal experiences with this. Jim?
Yeah, hey, I'll jump in because really in prepping for this, I looked at this again in terms of trying to find any data, and I think that Jason nicely summarized that, which is helpful. It's always helpful to have a little extra, and anecdotal experience only gets you so far. But I think of the number of operators, or I'll even say the number of soldiers or service members that I've taken care of in a career in medicine, in deployable units with multiple deployments. And I can't think of maybe more than one soldier that I would have to refer to a medical board for seizure disorder or epilepsy that had been brought on subsequent to a blast. That's not to say that some people would not sustain a head injury and have a seizure associated with it. Those are two different things, and that there is definitely an increased risk of seizure following an acute traumatic brain injury that increases with severity, that may or may not have much probability of sustaining or leading to actual trauma-related epilepsy afterwards. So that's not super helpful, but that's my experience. Steve may have a slightly different experience as a PA serving for a number of years as well. It's just not that common. My experiences mirrored that in the sports world of taking care of elite athletes with multiple TBIs or multiple concussions that don't develop epilepsy or periodic seizure disorder. Steve?
Yeah, thanks, Jim. And I want to make a couple comments based on some of the points that Jason and Jim both made, and that is that soft data doesn't necessarily translate well to the rest of the population. First of all, if you look at the timeline that our work has been done on, very few of these soldiers were TBI naive when they came to us. So even a baseline, that doesn't necessarily mean they haven't suffered previous concussions or head injuries, and that may be mild, moderate, or severe. We certainly have plenty of soldiers that work in this community that were boxers, bronco riders, construction workers, whatever, in their civilian life or in high school or college that suffered traumatic brain injury, some of them that led to loss of consciousness. So let's not assume that this data translates very cleanly to the rest of the population. The other thing to consider is this is a population of near continuous exposure to subclinical events. These are guys that are out on the range every day. These are guys that are breaching with explosives continuously. And for 20 years in war, the same cohort, many of whom we baselined back in 2002, 2003, are still around today. And they've been deployed dozens and dozens of times, having been exposed to lots of subclinical events, even if they've never experienced a clinically significant traumatic brain injury. But to the point about seizures, there has been some work done, EEG work done on alpha desynchronization and the changes in alpha desynchronization following traumatic brain injury, and kind of the smoldering epileptiform activity that happens following a traumatic brain injury that may or may not result in active seizures or active epilepsy, as Jim had pointed out. But there does at least appear superficially to be this odd event that happens in the brain. If you look at a typical EEG, not QEEG, but you're looking at a comprehensive EEG, you can see some of those changes following a traumatic brain injury. And I'll pause there.
Great. Thanks, Dave. So what I'd like to do now is roll into our first panel discussion. We're just past the halfway point. We're kind of front heavy in the questions. We've got a number that are coming regarding there's a slide on binaural beats. I apologize here. The question polls keep popping up in my slide. We've got a question on binaural beats. We've got a question on hyperbaric oxygen as a treatment intervention coming up here. We've got a brief discussion on psychoactive substances to treat TBI. So those questions are forthcoming in the presentation. So I just wanted to let folks know that. There was a discussion about where individuals, particularly in veteran status, can seek care for some of the complications. So I'll touch briefly on our Thrive program at UNC Chapel Hill. And then we'll have time at the end for another short panel discussion, kind of wrap up on any of those topics that we're going to touch on, or any others that emerge or that come to mind. So with that as the setup, I'd like to take maybe about 10 minutes here. And first I'll invite Wes to, Wes has been very active in the chat. Thank you, Wes, for managing that while I've been steering the ship here with the other co-panelists. But Wes, maybe take an opportunity to summarize some of the kind of the topics that have emerged. Maybe if there's any lingering questions that you feel the panel could be equipped to answer at this time. And while Wes is doing that summary, if there are any questions that anyone in attendance would like to ask, feel free to put those in the chat, and we'll be monitoring those here over the next 5 to 6 minutes. Wes?
Yeah, thank you. Some really, really great comments and questions in the chat. Clearly, we are speaking to a very well-informed audience here. We had comments about blood-based biomarkers and some great links to resources regarding the current iStat-Alinity, which is the FDA-approved blood-based biomarker that essentially tells you if the individual needs to be taken for CT scan. It's not meant as a diagnostic biomarker, but it is potentially helpful and field deployable for triage purposes. We had some great questions about SPECT scans, and there is some evidence that those are potentially more sensitive to mTBI than CT or MRI, but there's some logistical and concerns there, and barriers. It's not as readily accessible, not as fast as CT or MRI might be to detect those kind of red flags. But great idea to possibly work that into kind of annual or somewhat regular screenings for all of SOF, since those are potentially more sensitive scans. I don't know if anybody has comments on SPECT. A couple of other comments. I'm just kind of scrolling down. Concerns about the lack of documentation, especially early in OIF, OEF of TBI. That's an issue. We saw a lot at Fort Bragg and did a lot of education with providers in terms of how to diagnose and how to properly document mild traumatic brain injury. And especially early on, when you look at that kind of pre-2007 range, a lot of it wasn't accurately diagnosed and documented. And so that can create issues for people who are trying to get access to benefits and services. I'll pause there. That was a lot of the kind of a high level view of a lot of the comments, a lot of great discussion in the chat. I don't know if anybody wanted to comment more specifically on SPECT scans at this point.
Wes, I don't want to comment on SPECT, but I do want to comment on your comment on data capture downrange. One of the things we had the ability to do when we worked with and for Jim was to all our data on our SOF soldiers was handwritten and paper copy, and when our soldiers were medevaced from the battlefield, we tended to travel with them, so we were able to capture all that handwritten documentation and bring that home and collect quite the database of what happened to our soldiers in terms of TBI downrange. And that led to some additional work with DARPA, where DARPA began modeling some of the events that we were able to capture on either drone or satellite imagery, where we could go back and kind of trace the steps of the individuals that were involved in blast or blunt trauma events, and look at, again, the heterogeneity of the spectrum, where a guy that was right face first into the blast may not have been the soldier that was the worst affected. It may have actually been a soldier that was subjected to reflected wave off a wall. Many compounds and many of the targets we were involved with were multi-walled buildings and compounds with courtyards, and really it was the reflected wave that was causing problems. So thanks to DARPA for all the work they did on our behalf that kind of led to a better understanding of how blast propagates and causes injury in urban settings. Over.
Yeah, and thanks for your comment. That I just need to make a big disclaimer. During the introduction, Jason mentioned that I, was previously at Wood Montgomery Medical Center, so I was referring more to kind of big Army and not necessarily SOF in that instance. So just wanted to put that disclaimer. A lot of my perception is driven by my work at the Intrepid Spirit, where we dealt a lot with like the 82nd Airborne, but also had the privilege of being involved in the EVO Pro to conduct neuropsych evals. So I had my foot on both sides of it. But that comment was more specific to kind of big Army and a lot of our efforts to train Army clinicians. So.
Yeah, I think classically across the DoD, medical record keeping is a challenge, and it's messy at best. And just when things start to get under control, they decide, hey, let's switch our EMR again. And so there's going to be a very big disconnect. So one could view it in one of two ways. One is, I can't believe they're switching it. How are we ever going to connect the old records to the new? And that's going to be a challenge that will face clinicians who have to work in two systems, and for researchers who want to dive into those clinical records to make meaningful evaluations of the landscape. On the flip side is with a new start, there could be a new start, right? And I embrace that as an opportunity to standardize record keeping across the command, both within special operations and SF and conventional forces as well. So hopefully it'll improve our ability to study these injuries moving forward, because we'll have a system that hopefully works well and is implemented and hopefully better standardizes the information that's being collected around this particular condition. The panel is kind of focused more on the kind of blast related subconcussive impacts. One question I was asked is shooting at the range associated with brain injury? And these are all, pragmatic questions that affect, individuals daily. As Steve mentioned, there's individuals that have been doing this for 20 years, right? Breaching, blowing up doors and walls and shooting and doing that every day as part of training. And there's things that have evolved in the training environment to make things safer, lower net effective weights, raised ceilings, rubberized walls, those sorts of things. But, ultimately, if you're looking at the pictures here on the screen, firing a weapon may be very different than breaching a wall, may be very different than firing AT-4s all day or Carl Gustavs. And for the Navy special warfare folks, there's a lot of chatter, a lot of discussion around the impact of riding these boats and slamming into waves and having these kind of boat-related cumulative subconcussive impacts that many of them believe lead to some of the things that they're experiencing later in career and later in life. So as the civilian, I'll take a step back. I'll turn this over to Jim and to Steve to talk a little bit about some of the things that you've seen related to these topics. Steve, you've lived it probably more than anyone on this call. Maybe we start with you and kind of see what your thoughts are on some of these topics.
Yeah, so a couple thoughts. I can recall a day on the range before Just Cause in Panama, where we had chosen the 106 recoilless rifle as our anti-vehicle weapon of choice for that particular deployment. And this is long before anyone was talking about TBI. This is Just Cause was 1989, if I remember. and we fired 14 cases of ammo out of that weapon system that day. When we were back in the bay later that day, cleaning those weapons, I think we had 4 weapons and 14 cases of ammo, 8 rounds per case. When we were cleaning the weapons that evening, one of the guys came out of the team room with the TM, the technical manual for that weapon, and kind of chuckled out loud and said, "Hey guys, it says here we're not supposed to fire more than 2 rounds in a 24-hour period in training." Well, we had literally just gone through 14 cases of ammo. I actually had to go to the dentist and have a filling replaced because it had rattled loose on the range that day. So we think about, guys going to the range and firing Carl Gustavs and there's a 40-millimeter grenade launcher in the top left picture here, and these guys having just breached that room. But then there's a whole nother cohort out here that's getting their brain literally rattled as they're pounding the waves in these boats heading to shore or back out to the ship. And this clearly can't be healthy. And we do assess symptoms in these soldiers and sailors from these events. Guys come to us after a day of gunnery and tell us, I'm nauseous, my ears hurt, I have a headache, I have this smoldering, occipital lobe kind of throb. But I don't think it was until the early 2000s that we started really kind of putting thoughts on paper about collecting the data on the types of training these guys do and the amount that they do, or more importantly, ways to mitigate that damage. And there is a tremendous effort right now to kind of eliminate some of that threat to our soldiers, sailors, airmen, and Marines by minimizing the ammo you expend in training, or maximizing the use of the few rounds you can shoot. But one of my favorite anecdotes about this entire scenario is one day I went back to a squadron commander and said, "Hey, one of your guys is not doing real well. He's got a mild traumatic brain injury after a training event." And he asked me, he said, "What was his impact score?" And I thought that was an epiphany. The clouds had opened, sunlight shone through the storm clouds, and it dawned on me that commanders are starting to get it, and they need to get it more. And more soldiers are coming forward, and their frontline supervisors, the NCOs, and the young officers are making these decisions to protect soldiers and sailors' brains more often than we used to, and that to me is a huge win. I'm not sure I answered a question at all there, Jason, but I had to share that with you.
Well, so someone who spends as long as you did doing what you've done in service definitely can speak to this way more and way better than I could. Jim, follow that.
You can never follow Steve. Hey, just some comments. One of the hardest things from in this venue is to actually see who's in the audience under what roles. And I know in team rooms past and other MSOF events, I know a lot of the people by name from past history, so it's difficult. But I really think that our comments ought to be aimed at folks in the team room now. And I have a couple of thoughts. Steve hit the nail on the head in terms of the change in culture that I got to see probably in my last 10 to 15 years on active duty, in terms of commanders' awareness of brain health. The other piece that we haven't talked to at all specifically this evening is brain health in the sense of mental health, as opposed to physical health, which I automatically think is kind of an improper distinction. But since that's what we use in our regular terms, I'll just say that. And a lot of people, I think, on the call are quite familiar with the overlap of symptoms between PTSD and TBI. And that's kind of a really easy oversimplification to use diagnoses and a term like, post-traumatic stress disorder, which is a diagnosis that exists in a book called the DSM-5 that's been created by, a whole bunch of smart psychiatrists in a panel over the years. But there's a huge impact on mental health and mental performance that comes from work-related exposures. And I think that an easier topic to dive into is TBI in the sense of physical injury and symptoms that are much easier to talk about, like headache and double vision and difficulty walking. But it's opened the door to a lot of other very, very valuable discussions that I've been on the receiving end as a physician from people who trusted me over the years to talk about what we would typically categorize as psychological problems or issues with mood, anger, irritability, temper, violence, and then substance abuse. So I think, this is, again, one of those, comments without a specific question, but I think that our work in TBI has opened up a whole separate discussion in terms of mental wellness. So when we talk about brain health, that means a lot of different things to different people. But in terms of mental wellness and mental performance, a lot of that has driven attitudes towards having a cognitive performance coach in units to specifically work on cognitive performance, such as the strength coaches we have that work on physical performance. And these things are certainly interrelated. So I think that our work over the past few years has really helped to break down that artificial divide between a mental health issue and a physical health issue, because to me that's just not the case. We should be looking at people as whole people. So that's been a really satisfying thing to see change from, my early days as a butter bar in 1989 and just to last year within the SOF community. I think I should shut up so we can get to more practical questions.
Thanks, Jim and Steve. I'll just add one thing here and then move on to some of the clinical intervention questions that we have coming up. So I know that blast-related subconcussive impacts, low-level blast exposure, training environments, all of those are things that have come up in discussion with the SOF community. And to Steve's point, there's rightfully so a heightened awareness of what the impact of regular training occupational exposures has on brain health, both short and long term, how it impacts mission readiness and and long-term health. And so we've done a number of things. Steve, while he was still at the SMU, incorporated blast gauges to kind of work with DARPA to establish the utility of blast gauges in this population. We've had an opportunity now speaking about command interest. We were approached a few months ago where we actually engaged in our first study within the training pipeline itself, tracking blood biomarkers in students or trainees within the pipeline over the course of their close quarter battle training period, where we were tracking low-level blast exposure. The safety officer at the SMU is the one that produced the blast gauges because he was interested in making sure the individuals were safe in their training. We've had 2 assault medics who on their own independently affixed blast gauges to NATO silhouettes and put them in the CQB environment and blew charges to see what the typical or expected exposure would be for an individual. So we know, based on typical training volume, the types of charges that are being eaten, for lack of a better term, and how frequent those charges are being eaten, to where we can now kind of program and estimate what that blast exposure looks like over the course of a training cycle, over the course of a deployment cycle, over the course of a career. And we're using that information to dive into some of the research data we've discussed, both when they join the organization as well as right before the EvoPro assessment, to look at the effect of that blast exposure for that individual, and to explain some of the changes that we're seeing in our outcome measures. And we're taking it a step further, and we're diving into those very messy medical records to look at what the clinical staff has identified as clinical conditions worthy of intervention, to see if any of our objective measures can link to that as a predictor, so that we could remove the subjectivity of it and really focus on developing objective measures that target some of these conditions. So we're excited about what the next steps are, and hopefully we'll be able to join you in a couple of years and talk about some of the advances there. We are at 8:30. We have about 30 minutes left, and I do want to get to some of the remaining questions that were asked. One of them was asked specifically by a speech and language pathologist. And I nor anyone else on this call, I think, are going to be experts to answer this question. But I did find some evidence, and I wanted to share that with you. Our Thrive program has an incredibly talented speech and language pathologist in Dr. Lindsay Biome. And so if anyone still has lingering questions, I'm happy to connect you with her to kind of talk a little bit more about this as an intervention. But essentially, the mechanisms behind how binaural beat stimulation translates into the changes that we hope they do are still really much unknown. There's a lot of conflicting and inconclusive evidence. Having said that, kind of the lack of the understanding of the mechanism aside, when you look at a meta-analysis that was published looking at different studies that engaged or incorporated binaural beats as a treatment intervention, we see that that there are effects on memory, there are effects on attention. There's a number of studies that have looked at general analgesic effects on the individual, as well as looking at reducing anxiety. Overall, though, when you look at all these studies that have been incorporated in this one meta-analysis, the studies typically have very small sample sizes. There's a lot of publication bias that is at play. And what I mean by publication bias is not the papers that have been published have bias. It's the papers that haven't been published. There's a lot of science, a lot of really good questions, a lot of interventions that are of interest to individuals. And sometimes there's a phenomenon in the scientific space where you engage in an intervention, you think it'll work, it turns out it doesn't, and it doesn't have that sexy p-value less than 0.05, and so it doesn't get published. And so what that does is there's a inclination in the scientific literature that tends to skew the things that are published around things that had statistically significant findings and positive effects, and those that were negative tend to be ignored or dismissed or dropped so that there is a pursuit of another intervention. So that's what I mean by publication bias, and sometimes in interventions that are rather innovative or maybe new, like binaural beats for this particular treatment, it's hard to kind of really find a good balance of the literature. It is important to note that, at least in my search, and it was a very cursory one because this is outside of my lane, that there were no studies that were done in soft populations that I could find. And so the effectiveness of this as a treatment intervention in that population that is near and dear to all of us on this Zoom tonight is still unclear. Heather, I see your comment. Thank you. The next question involved hyperbaric oxygen, and in particularly the effectiveness of them. So I just want to be very clear that upfront, the FDA has not approved concussion or mild traumatic brain injury as indicated for hyperbaric oxygen therapy. So that aside, it is available in off-label environments. In other words, you wouldn't be able to go into a hospital, approach their hyperbaric facility there and say, I've got a mild traumatic brain injury and I'd like to get treated. That is likely not going to occur in an on-label in healthcare scenario. There are a lot of private clinics that have opened up that offer hyperbaric treatment for a number of conditions, including those that are indicated. And they'll take your money and you can get treatment, and people have had some positive responses there. But I just want to be clear and upfront there as far as reimbursable or insurable or anything along those lines. Right now, it's just not there because it's not FDA approved. And I guess in theory, why would it work? Jake alluded to this earlier in one of his discussions about the mismatch between the what is demanded of the brain and what is being supplied to the brain. And so the brain requires, energy, it requires glucose, it requires oxygen. But at the same time, we see all these elevated kind of needs. We're also seeing a decrease in the amount of cerebral blood flow. And so the theory is that if the brain needs oxygen to recover, and the brain gets its oxygen, say, from the blood, and there's a reduced blood flow, we're not going to necessarily be able to change blood flow per se, but what we could do is saturate that blood with even more oxygen so that the uptake is a little greater, and then hopefully it helps the brain recover sooner. And so that's the underlying kind of theory behind this, and it's all based in large part on that neurometabolic cascade. Again, hyperbaric treatment is available as off-label. And the other thing to clarify also is that not all chambers are made equal. So there are hard and soft shell chambers, and the hard chambers are actually FDA approved for delivering hyperbaric oxygen therapy. They can withstand greater pressures. They resist mold and bacteria better, which is always great, especially when you're going to be sealed in one. And they're also sealed to deliver 100% oxygen. And so when you look at randomized clinical trials that employ hyperbaric as a treatment intervention, they are typically those that are employing hard chambers because of all these abilities to control your environment in a very meaningful way within that chamber. There's a whole market out there that sells soft shell chambers, and those tend to deliver about 25% oxygen. They seal via a zipper, so there isn't like a vacuum seal of sorts, and they typically can only withstand lower pressures. And when they were created back in the day, soft shell chambers were actually never meant to treat people, but they were meant to be a very short-term and portable solution to put an individual in during transport before they could arrive at a legitimate, hard chambered hyperbaric facility. And so in austere environments, in deep dive accidents, the soft shell chambers were the short-term gap to getting someone into a hard shell chamber where they can be treated under a very controlled environment. There has been some work by David Sifu and his group at VCU. He's done a number of trials. They were published maybe about 7 or 8 years ago. And in one of them, following a randomized clinical trial where they had 3 groups, one was a sham, one was some oxygen, and the other was 100% oxygen, or if I recall, maybe they were both 100% oxygen delivery, but at different pressures. They found that there was no evidence of efficacy by 3 months post-compression to treat the symptomatic and cognitive and behavioral sequelae of post-concussion syndrome, particularly after combat-related mTBI. So this was in a military service member population. And alternatively, or additionally, I should say, there was another paper that group published that looked at no significant differences on individual or total scores on the PTSD checklist or the Rivermead post-concussion symptom questionnaire. So based on Sifu's work, in large part is why the DoD did not really authorize hyperbaric as a viable treatment in their healthcare environments. There's a discussion that is also quite active in the SOF community around psychoactive substances.
Jason.
And I'll turn that over to, oh, sorry, Jim, go ahead.
Hey, sorry, I just want to, before we move on,
yeah, sure thing.
The topic of hyperbarics, I think the comments and the information that Jake presented earlier on glymphatics is huge. And here's why I think that, we're talking about brain health today and TBI, but in my current role, I see people that are coming to me now with a variety of constellation of symptoms that are attributed to other things. And there's a whole bunch coming with long COVID right now. Long COVID means a lot to a lot of different people, but there are people also in the chronic fatigue syndrome world. There are people in the chronic Lyme world, but there are a lot of people that fall into these very hard to define chronic illnesses that seem to respond to changes in blood flow in the brain. And I'm not suggesting that hyperbarics is something that we should, I'm not saying anything different from what you suggested. What I do think is specifically in the role of TBI and what we're talking about, I think that there's going to be a real role for intervention in modifications of cerebral blood flow. And there was a couple of comments down in there. Christine Ray Olmsted dropped it in there as well. But we typically see a lot of people with a history of traumatic brain injury that we've treated over the years, over thousands, over 10 plus years, with stellate ganglion block, and until recently had not done left-sided blocks. And now we see, at least anecdotally, this is all unpublished, that seems to make a big difference in people with history of TBI. And it's very hard to tease out because a lot of the PTSD symptoms that are described are things like the brain fog, like very nebulous, hard to describe symptoms. But there is human evidence and studies that go back into 2013 of changes in cerebral blood flow following stellate ganglion block. And I think that might be what explains some of what we're seeing anecdotally for people with their responses to things like long COVID and chronic fatigue syndrome. So this is where, whatever, 2 worlds, 3 worlds collide in this, and we sometimes stumble into something. But I think the work in lymphatics is going to be super interesting to follow. Over.
Great. Thanks, Jim, for chiming in and adding that. We've got one more question here before we roll into a very brief overview of the Thrive program. But, a question that, as I mentioned, came up from one of the attendees here, and one that is an active conversation, is that around the effects of psychoactive substances on TBI. And, the bottom line here is that there has been a phase 3 study in humans that shows that methylene methamphetamine, man, I can't believe I knocked that one off, or in other words known as ecstasy, using that to assist therapy has been found to be highly efficacious in individuals that have severe PTSD. The treatment is safe. It's very well tolerated in that particular phase 3 trial. I'll note that the studies focus primarily on those with PTSD and not traumatic brain injury per se. So that's a distinction, although those two conditions are often difficult to disentangle, especially with in individuals that have the exposures that many SOF operators do. With that said, I know Steve has been very active in discussions about psychedelics and psychoactive substances. So I'll turn it over to Steve just to give a kind of a brief high-level overview of kind of where things are at and directions people are interested in going, particularly in this population. And then from there, I'll turn it over to Wes, who's looked at it briefly as well, to add some concluding thoughts to this discussion before he takes over and starts talking about the Thrive program. So, Steve.
Thanks, Jason, and I'll be brief. All I'll say is that there are a couple of very small studies that show really significant promise using various substances. The MDMA study that Jason mentioned is one of those, but there are several commands and services in our Department of Defense that are looking at ways to treat PTSD for the active duty population in much the same way we've been treating PTSD in our veteran population. We've got some work coming up here with several senior commands in the military looking at various substances. But as you can well imagine, this is a very sensitive topic. No one is willing to jump up and down right now and say, bring this to my medical treatment facility. We're ready to go today. But many are saying we are very interested to include commanders of significant commands. So more to follow on this. The preliminary data is very exciting. I'm thrilled to hear some of the comments I'm getting from fairly large populations of folks that have not been studied specifically, but anecdotally have shared their feelings and their findings with us after the fact. So more to come, and I'll just leave it at that for now, Jason.
Thanks, Steve.
Yeah, and I don't think I would have anything else to add on that. It is preliminary, but it is a really interesting and exciting emerging field of possible treatments. So hopefully we can do some good work in that area. All right, so Thrive, Transforming Health and Resilience in Veterans, is a program that was, I guess, founded just over a year ago through a major gift from the Avalon Network. And the goal was really to bring a model of multidisciplinary care that was being done throughout various sites in the DoD and VA systems, and be able to bring it to veterans and first responders. And you can see the mission statement there on the slide that Jason has. So as somebody that came from the intrepid spirit and saw the benefit of a holistic, multidisciplinary evaluation and treatment program. It's really exciting to see that this has been established for veterans. At UNC, we started seeing patients, Jason, correct me if I'm wrong, but just recently back in March, April was the first patient, and have been ramping up at a pretty good pace, focusing primarily on a 3-day evaluation program. So just, kind of a large overview to this. Again, it was established through a major gift. And what's great about that gift is that it reduces all barriers to care. So the veteran or retired first responder coming doesn't have to worry about the logistics, doesn't have to worry about the insurance costs, those sorts of things. We have a great staff that take care of those issues and ensure that they can just be focused on getting to our site and getting the care that they are seeking. And again, it's a holistic, multidisciplinary program for individuals with a history of TBI and PTSD as well. And it's so important because, if we just look at, the rates of TBI in the military, we all know that those were the signature injuries of OIF, OEF, OND. So we know that TBI is a huge issue. We look at the rates of TBIs that have been diagnosed, something like over 400,000 since 2000, and that doesn't even begin to scratch the surface because of all the undiagnosed, misdiagnosed, unreported issues. So we know TBI is a huge issue. We see it, we live it every day, those of us that care for it. But also when we look at suicide, 20 plus veterans commit suicide every day, and that's greater than 2 times the national average. And that's coming from a group that represents only 5% of the population. It's a really powerful quote there by Tom Satterley of the All Secure Foundation, that terrorists have not been as effective at killing American soldiers as PTSD. And just the yearly suicide rate for combat veterans was higher than all the casualties of the Iraq and Afghanistan wars over the past 20 years combined. So there is clearly a desperate need for services to assist veterans who are presenting with issues that are possibly related to TBI and PTSD. And so the Thrive Network is really this kind of somewhat of a unicorn in the UNC system, or the Thrive program is a unicorn in the USC system, where it's a combination of the university and the Matthew Gaffeller Center, which is in the Department of Exercise and Sports Science. The Thrive program falls under the Matthew Gaffeller Center, but it's done in partnership with UNC Health and specifically the School of Medicine, the Department of Exercise and Sports Science, and the Matthew Gaffeller Center is under the College of Arts and Sciences. We also partner with UNC Physicians Network and all of the different entities that fall under that. So bringing together all of these different UNC affiliated entities, it's really a unique combination. It presents its challenges, but it also allows us access to a ton of resources that we can then bring forward to help serve the veterans. So currently we have a 3-day evaluation program that's really modeled after the evolution protocol that was referenced earlier in the Intrepid Spirit Networks, where over 3 days, the veteran gets a very comprehensive, multidisciplinary evaluation that if they were trying to seek this on their own, it could take 6 months to a year if they were even able to get authorization or approval to get all of these services. I mean, anything from, neuropsych, musculoskeletal evaluations, vestibular evals, nutritional consultations, imaging. I know I'm forgetting stuff. Jump in if I'm forgetting anything significant. Even psychology, speech and language pathology. There's even some brief treatment that occurs within those 3 days. And eventually what we want to work up to is an intensive outpatient program, a 2 to 3 week program that builds off of that evaluation and provides really intensive services to jumpstart the recovery. And then they can take that out into their community where they can get the follow-up services that are needed. That's the ultimate goal. Currently, after that 3-day evaluation, we give them a summary report and a list of recommendations. That's really kind of a to-do list for their primary care doc. And then we'll follow up with them for at least a year likely longer, just to make sure that they're getting connected to the things that they need to get connected to. Anything else that you want to touch on, Jason?
I just want to highlight, Wes and the clinical team are incredible, talented clinicians that are all teaming up here to really care for the veterans. Everyone that has come through the program has expressed gratitude for the program and the information that we are able to share with them. As Wes said, sometimes you can go years bouncing around from one specialty to another, and you can get all that information in our program and others like it, in a very short window. So we're very proud to do it. For us, it was a logical extension of the research partnership that we've had with the SOF community. It is not a program for SOF in particular, but we are certainly well equipped to manage it. A former Special Missions Unit Command Surgeon is our medical director. He's an individual that understands the population and what comes with a career serving in SOF. So we're very excited about that. There's a couple of folks on the call here today that are part of our team that have joined. Sammy Rodriguez, former 7th group medic, is our veteran outreach coordinator. Marcus Peoples also served. He's our clinical navigator. I saw a note here from someone in attendance saying that they're looking at the application and filling it in. So your first response is probably going to come from Marcus. So we're excited to welcome anyone here into the program or anyone you feel could benefit from it. So thanks, Wes, for that overview. Steve mentioned the timeline that he kicked off, about 20 years ago in this space. Over the last 10 years, we've built up our attack forces initiative. We've included additional commands. We're still kind of thin. We'd love to engage in working with, MARSOC forces and Naval Special Warfare. And so if anyone here has an in with them or an interest in engaging us with those groups, feel free to reach out to me directly. But then ultimately in the next 10 years, where I think we want to go is really, advancing warfighter brain health. And brain health, as we've learned today, is a very broad and encompassing topic, but it's something that we want to pursue. We want to ensure that our SOF forces are ready for what is coming with our kind of near peer adversaries, and we want to make sure that they're safe, and that when push comes to shove, that our guys come back, they come back healthy. There's an infrastructure in place to care for them, both short term while active duty and long term in their retirement. So with that said, we have a little bit of time here. So I'd like to roll into, having said just that, into our next brief panel discussion. There were a number of questions about how we engage family and spouses and children in caring for SOF service members and veterans. I'll speak to the Thrive program in particular. Spouses and children are welcome. We actually want spouses to come. I don't believe we've had any children attend these sessions, but in our longer kind of treatment phase of the program that we'll establish once we relocate to a larger clinical footprint, our plan is to engage as much of the family as possible. To use a term that was described to me is, we're training people to, be a different kind of puppy, and we need people back home to know how to care for the puppy. And so, we're taking individuals that are coming in with issues and deficiencies. We're targeting what those are. We're going to improve them. We're going to make them better and different. And then when they return home, there needs to be an environment that understands the change that has taken place or the change that is continuing. And that could be as simple as, from a nutritional standpoint, making sure that people are on the same page as far as what meals are being prepared and how that's occurring. It's understanding how to initiate a difficult conversation, because those are things that we're working on with patients in our programs. And so all of that doesn't occur if we just bring in the veteran by him or herself, address it, and then have them return back to a family environment. So I'll stop there. I'll turn it over to Wes to speak a little bit more about spousal engagement during the evaluation process of our program. And then I'll turn it over to Jim and to Steve, who have lived the transition from active duty to veteran status and invite them to share whatever experiences, whether those that they know in colleagues or even their own personal stories around the value of engaging family and strategies that they might invoke to facilitate that for those here who are hoping to help their veterans as well.
Yeah, thank you. Having a spouse or significant other come along is so valuable. They are an incredible source of information and often have insights that the patient themselves would just never have. And so it's very, very valuable as a clinician to be able to get their input, their perspective on things, and then also to be able to work with them and make sure that they are taking care of themselves. I mean, you can't be a good caregiver if you're not taking care of yourself. And then providing them with the information and the education. I think a lot of times just grounding some of the behaviors that they're seeing in the science and in medicine can be very helpful. It normalizes it to a degree and lets them know that that their spouse isn't crazy or they're not crazy for what they're seeing, and that they're dealing with things that are a symptom of a medical condition. And a lot of times that can be really helpful. And so caregiver support is something that we definitely talk about, we think about, and we want to be sure we include in the IOP if that's something that our patient population is interested in.
Steve, Jim, opening up to you.
Yeah, I'd like to hop in here if you don't mind. Having been through an inpatient TBI, PTSD treatment program, I will tell you that there is nothing more valuable than having a loved one there to see, to understand, to talk with the providers, because it just clearly does not translate well, right? This is not, honey, I have nail fungus and I need to put on, Penlac, 6 days a week. What your spouse needs to understand, or what the patient's spouse needs to understand, is not something that comes very easily from the patient's mouth. The patient is having a hard enough time struggling with the diagnosis and what he or she has just learned from those healthcare providers. So it really is an important conversation that needs to take place between the team, the holistic healthcare team, and the caregiver, the spouse, the significant other, the kids, whomever that soldier, sailor, airman, or Marine is going home to. Thanks.
Jim?
I think the pause was for me. Hey, I just want to reiterate that I think that, maybe a silver lining, that's probably not the right terminology, but an upside of 20 years of prolonged combat in this country has really done a lot to bring the value of the military spouse and the military family to the forefront, and certainly within the SOF community. And just thinking back to the pre 9/11, my time in the military, even at the inception of the thing called the Family Readiness Group, which was some kind of a, not even really an idea, to see where we are now. And just props to MSOF, who's running the show here, who's involved and led really by military spouses, and the attempt to try to bring good science to this community, and to bring people such as those of you who run the Thrive program, who involve military spouses on your planning committee. I mean, that's just an indicator of not just flapping your gums and talking the talk, but walking your walk, and actually really putting resources behind the military family. So that's a thanks. Convoluted thanks, but well done.
I am looking at the clock, and I'm not seeing a lot of questions pop in on this particular topic. But I do want to impress upon everyone that there was a lot of information. Well, we feel as panelists that there was a lot of information that we tried to squeeze in here. When the topic of soft brain health went out for this particular deep dive, we got questions across the gamut, and you saw those questions across the gamut as we went through them here. many of those questions could stand alone as its own deep dive event, if I'm to be honest here. And so what we touched on were some high level points, some things for you to think about, so that when you do meet with your primary care, or when you are speaking with your spouse, you have some additional information on hand to guide next steps and care. And if that is with us at Thrive, fantastic. We would love to see you. If it's elsewhere, we want to see you do what you're able to do. So if there's anything that any of us on the panel can do to assist, feel free to reach out. It is currently 2100. I attended a conference last week with Steve. I saw him get up and leave a room when the speaker ran late, and I would be remiss if I didn't end this on time. But before I do, I do want to thank my fellow presenters, my co-panelists, individuals that I respect tremendously for their heroism, for their service, for their commitment to helping veteran and active duty populations, and in Jake's case, the future brilliance studying the SOF operator moving forward here in the next several years. So with that said, I would like to thank everyone for attending this evening on behalf of our team in the Gefeller Center and our extended clinical operations team in the Thrive program. With that said, I'll turn it back over to Kaylee and to Lindsay to wrap things up this evening. Thank you.
Awesome. Thank you. Y'all, we appreciate you joining us here tonight, for submitting all the questions in advance, for talking to us in the months in between, sharing your concerns, your questions, your confusions that you have about what you're seeing, experiencing, or people you're helping care for in the community. So we live an intense community and lifestyle, and if it weren't for the person to your left and your right, sometimes you're left without answers. So we're here to help get them to you and bring you the best of the best to help you inform that journey. We hope you got all your questions answered. If you did not, please consider emailing us at home@msofc.org. You can also contact us through our website, LinkedIn, or Facebook. We want to give extreme thanks to our panelists who rallied through the weekend and last month in our team room, and went above and beyond for you all tonight. So if you have anything further for them, please reach out and we will get it out in the follow-up email and on our blog. And with that, we will not keep you any longer. So have a great night, and we look forward to seeing you at the next team room on November 21st and the following deep dive in December.